All right, let's go over the schizophrenia packet and do our tutoring. So I added a lot of these images in here because I think it really helps my visual learners. So these are kind of just some of the things that occur within schizophrenia and psychosis. Schizophrenia, psychosis is usually going to develop in adolescence or in the early 20s. That's like prime time. We have positive symptoms and negative symptoms. Remember, I always dictate these as a plus sign and a minus sign because it's not good or bad. It's positive symptoms are when things are added that should not be there. Hallucinations, delusions, illusions, disordered thinking, loose associations, catatonia, where negative symptoms are things that are taken away that should be there. A person should be empathetic. The apathy, so that empathy's been taken away. We're supposed to be social beings, but we have social withdrawal, so that sociality's been taken away. We should have a bright or pleasant affect, where these people are going to be flat and blunted, so that affect's been taken away. Poverty of thought, meaning we can't formulate thoughts. There's nothing going on. And then the lack of motivation to do things and the inability to experience joy. So those are things that have been taken away. The ability to feel joy is gone. The ability to be motivated is gone. So let's look at some of our terms. We have hallucinating. That's going to be hearing, seeing, smelling, tasting, or feeling things that are not there. We have delusions, which are false, fixed ideas. We can have delusions of persecution, which is where you think someone or something is out to get them. Or delusions of grandeur, which is where they feel as if they are the best thing on the planet. They are the king. We have illusions, which is the misinterpretation of something that is there. So where a hallucination is, I see a snake in the corner and there is nothing in the corner. Where an illusion is, I see a pencil, but I see it as a snake. There's something there. It's just not what I'm seeing it as. And then we have our ideas of reference, where we believe that events are happening for them. People on the TV are actually talking to them. Everything's kind of occurring in a way that it's not. We have that lack of motivation is avolition. That inability to experience joy is anhedonia. Poverty of thought and speech is alogia. And then that blunt or flattened affect is going to be no expression. So hallucinations, sensory impressions without internal stimuli, real stimuli that's misinterpreted, and delusions or false fixed beliefs. So this is really good images that kind of go over the difference between them. Okay. So some of our medical treatment for schizophrenia, we have our conventional antipsychotics that treat only the positive symptoms, and they have a lot of side effects. We have atypical or second generation antipsychotics, which have fewer side effects and can actually treat some of the negative symptoms as well. Okay. So our first generation antipsychotics. We have high potency and low potency. Chlorpromazine is a low potency. Haloperidol is a high potency. Potency refers to like how severe the side effects are going to be. You can still get EPSs with all of them. You can still get neuroleptic malignant syndrome with all of them. The big way that these are going to work is they're going to block dopamine. And we can have EPSs, which I'm going to talk more on the next page, so I'm not going to go into that right now. And neuroleptic malignant syndrome, very similar to malignant hyperthermia, which you learned in med-surg about post-op care. The treatment is pretty much exactly the same. We stop the med, we give cooling blankets and antipyretics for the fever. We give diazepam for seizures and rigidity, and dantrolene to reverse it and for those rigidities. They're going to go to the ICU, and we have to wait for 2 weeks before we restart any type of antipsychotic. That is life-threatening. The other one that is life-threatening is acute dystonia. This one is life-threatening because it's that muscle contraction of the tongue, face, neck, back, but also the larynx, which can block off the airway. We have pseudo-Parkinson syndrome, where you have that shuffling gait, flat affect, drooling, tremors, but you don't have Parkinson's. Akathisia, which is going to be that restlessness, pacing, tapping, rocking, moving. Oculargic crisis, that's where you're kind of stuck looking upward. A lot of times for these, our dose is lowered and we're given things like benzotropine or diphenhydramine. And we can also get irreversible tardive dyskinesia, which is that lip smacking and tongue movements. Once again, we have that neuroleptic malignant syndrome. You need to know this, and you need to know the treatment. And you need to know that it's life-threatening and a priority. Okay. Our second and third gens, these are going to be clozapine, risperidone, aripiprazole. They're going to have less side effects and treat both positive and negatives. So some complications that we can get. We can have diabetes. This is going to be new onset or loss of existing control of diabetes, so we have to really monitor those glucose levels. They can get weight gain, metabolic syndrome, high cholesterol, orthostatic hypotension. They do come with anticholera effects and agitation. These are contraindicated in clients who have dementia. So those who have dementia and psychosis have to have a first generation. The other thing, I highlighted clozapine because that one causes that agranulocytosis, and that needs to be monitored very carefully. Because remember, agranulocytosis can be very fatal. Okay. So I've added in, if you look through your packet, you have the Nurse in the Making. It compares first and second gens. It talks about tardive dyskinesia, EPSs, and neuroleptic malignant syndrome. Talks about contraindications and our nursing considerations. So just kind of knowing that. I have also added a kind of like a drug card from ATI on both first and second generation antipsychotics. Just for you to look over, it kind of gives good little bullet points, just in case we forgot about pharm. Because remember, pharm follows us. It's not going to go away. Okay. So data collection, or the assessment for schizophrenia, is going to be assessing the content and themes of hallucinations, delusions, to make sure we're safe. Remember, those command hallucinations, those are a priority. If the hallucinations are telling the client to do something to themselves or something else, or someone else, that is a priority, and they should not be left alone, because we do not know if they're going to act on it, and there's a really high chance that they will act on it to stop the voices. Okay. Delusions of persecution, issues that come along with that is they're going to be very suspicious of others. So you may have clients who, if another peer, it looks at them the wrong way, they may harm that peer because they're suspicious of them and they feel threatened by that person. So we got to really monitor that for safety. Remember our Maslow's, these people may refuse to eat because they feel as if we're poisoning the food. So some things we can do for that is that prepackaged food or buffet styled meals where they self-serve. We are going to observe for triggers. We want to help the person think in a logical manner. We want to observe if they have any psychotic features. Biggest thing, 9 times out of 10, we say therapeutic communication, open-ended questions, things like that. This is the one time where you want close-ended questions and be very brief, because you're not going to have their attention for very long. Okay. And then our interventions. We do not want them to use alcohol or other drugs with our antipsychotics. We want to use a calm and caring approach. And when they're in a hallucination, we want to state reality and help the patient return to reality, but we do not want to challenge or feed into their hallucination. So this is a very tricky, there's like a really fine line. If they say, oh my gosh, I'm hearing the voices, do you hear the voices? Don't tell them voices aren't real, because to them, they are very real. You're going to say, I do not hear them, but you seem very afraid. Can you tell me what they're saying? Things like that. We have our neoplasms, which is where they make up new words. Word salad, where we have words and phrases and fragments all tossed together and they make no sense. We have our expression of ideas that don't logically connect. We also have clang association, which is where we have a lot of rhymes and things like that. And then you have another page about schizophrenia spectrum disorder. So kind of look at the phases, because it's really good there. It has a good piece of our positive versus negative and our nursing actions. So it kind of sums up everything in one little page. And that is it for our packet on schizophrenia.